Good morning. Welcome to the Circle of Friends Train the Trainer webinar. My name is Kathy Boyer-Schussel, Project Manager for KC Communities for All Ages, an initiative of the Mid-America Regional Council. I'm also a member of this year's Age Positive Planning Committee. Many of you in attendance today learned of Circles of Friends during the Age Positive virtual conference held last September. The Circle of Friends workshop provided an overview of the program, and there was sufficient interest expressed by those in attendance to learn how to organize and implement the program for your stakeholders. So that brings us to today's training. The presenters for today's training are Dr. Marla Bergweger and Dr. Max Zubatsky with St. Louis University. If you attended the Circles of Friends sessions in October, you will remember Marla. She is a professor in the School of Social Work and executive director at the St. Louis University School of Medicine Gateway Geriatric Education Center. Her social work degrees were completed at Kansas State University, University of Kansas, and Washington University. She has authored 4 books and 100 book chapters, journal articles, and scholarly publications. And her primary areas of research include family caregiving, cognitive stimulation therapy, and driving and mobility, with social isolation and loneliness being a recent area of focus. Dr. Zubatsky is an assistant professor and program director in the Medical Family Therapy program. He received his doctorate in marriage and family therapy from the University of Minnesota and postdoctoral fellowship from the Chicago Center for Family Health and Medical Family Therapy. His research and clinical interests include caregiving, geriatrics, integrated behavioral health, residency education, and provider wellness. He has published over 15 articles, media briefs, and book chapters in the aging field, and has a new book called Self of the Therapist in Medical Settings, a training book for new therapists in healthcare. He is the director of the Memory Clinic at St. Louis University, where Circles of Friends is one of the services provided at the clinic. I would also like to introduce Danielle Wooten, Strategic Initiatives Director, KC Shepherd Center. KC Shepherd Center will provide regional leadership to offer peer support to organizations that choose to offer Circles of Friends. Danielle will be their point person for this effort and will provide more details at the conclusion of today's training. Thank you for your interest in Circle of Friends. And now turning this back to Marla and Max.
Thank you, Kathy. I'm Marla Bergweger, as you heard, and I'm familiar, hopefully, to some of you who heard the presentation I made at the September event. I really am excited that we've been invited back to provide more information about loneliness and social isolation, and particularly related to the Circle of Friends training. This intervention is one that we are very pleased to be able to introduce here in the U.S. As you'll hear in much more detail, this intervention was developed in Finland and is evidence-based. And so you'll hear lots more. I don't want to spoil that. So we want to start with a poll so that we can learn a little bit more about the 70 of you that have joined us today. So I believe Carmelia is going to pull up. And if you would just click on your discipline, we can learn who's here with us. It looks like social work was in the lead, but other is now taking over.
We'll give a full minute for you all to complete this portion. So we have about 15 seconds left.
Thank you. While we're waiting, I do want to mention that earlier, we were having a little bit of trouble with my screen freezing. It would only do so for a few seconds. If that should happen, just know that I'm only gone momentarily, but I'll be back. And hopefully it won't happen. I followed Carmelia's guidance and closed everything out, and the sun is out, which should help. Sometimes it has, if it's cloudy here in the St. Louis area, my internet connection is not at its optimal best.
All right, and the poll results are being shared.
We appreciate you people using the chat for the other section.
Okay, so it looks like we're a pretty diverse group. That's great. And I think it's very important that we are a diverse group, disciplinarily speaking, because loneliness and social isolation are issues that really span and should span in our awareness across all disciplines in health and social service professionals. So thank you all for sharing that, and glad to see so many social workers. I'm completely biased about that, obviously, with all my degrees being social work. So all right, and it looks like I'm back here to having to advance in that way. All right.
And if the poll is still displayed for you, just click to minimize that on your screen, please, participants.
I did that. Thank you. Thank you. So here are disclosures. And I do want to share that the work that we do at St. Louis University is funded by a grant from the Health Resources and Services Administration. St. Louis University, or SLU as we call it, has been funded to do geriatric education for about 30 years now by the federal government. So we are very fortunate that we were renewed in 2018 for another 5 years. So we'll be able to continue this work. I'm going to have to just keep hitting that one. So our objectives for today's session is that we will introduce ideas and concepts and research related to loneliness and social isolation to enable you to analyze the evidence for non-pharmacologic interventions, specifically Circle of Friends, and to be able to look at issues related to who is appropriate to be involved in a Circle of Friends group, and then to provide you with the evidence that supports Circle of Friends in some of the skills, knowledge needed to be able to offer this degree, this intervention. We're very excited that there is such interest in the Kansas City area, and particularly grateful to the Casey Shepherd Center for offering through Danielle to be the hub. And we're excited. I think that we're spreading the word about this really wonderful intervention that you'll hear more. So this training really is targeted for those who are interested in becoming facilitators of this training. As I've mentioned, the training was developed initially in Finland, and we've been given great support from the founders to adapt it here in the US and to spread the word. So our goals for offering the training really are to introduce you to this very unique kind of group intervention, and you'll hear about the unique features of it, to really understand ways and strategies to engage older adults to be able to talk about their feelings of loneliness and social isolation, and also to facilitate a reflective component of this, which is really one of the unique features. So what we'll do today, as I've kind of indicated, is we'll provide an overview. We'll talk about Circle of Friends, talk about recruitment, selection, planning, group process and dynamics, and evaluation and termination, and then again back to the reflective cycles. So what I'd like to do for the next few minutes is to kind of provide some context and some background on the issues of loneliness and social isolation, My apologies to those that were on the webinar back in September. Some of this will be repetitive for you, although there's certainly some updates to it. Research is just exploding right now in this area. So I'm trying to stay on top of the latest findings as they come out. But I did want to, for those that were not able to participate back in September, I did want to provide this foundation so that you understand the extent and the intricacies of these experiences as older adults report them in research. So as you can see here, Jane Sachin, who is CEO of the SCAN Group Health Plan, refers to loneliness and social isolation as an epidemic in plain sight. And I think that there could not be a more apt description. It is not a new phenomena. By any means. The pandemic that we're all living in has certainly brought considerable attention to the issues, in part because we've all experienced loneliness and social isolation in some form across all ages during this period of time. And I think that's helped us to know what older adults are experiencing, and with the inability of us to engage with older adults, particularly those that live in residential care facilities. I think this has become something that we're all aware of. My fear is that after the pandemic, and I have to believe there is an after the pandemic sooner than later, that we'll forget. As our lives return to whatever the new normal is, at that point, I fear that these issues will be forgotten. So I'm really glad to know that all of you are here and that you're interested and committed to learning more about this issue. So let's start with some basic definitions. The terms loneliness and social isolation are used interchangeably. Even within the research, they're used interchangeably. But in fact, they are two very distinct kind of experiences. If you think about loneliness from the perspective of it's a qualitative perception by an individual in which the expectations that we have for the relationships in our lives are not being met. So you can be around people and still be very lonely. And I've got some statistics to share about that as we move through this. So loneliness really is a very individualized perception that we all have. And it's a disconnect between what we hope our relationships will be and what they actually are in our estimations. So social isolation, on the other hand, is more of a quantitative kind of assessment that is literally a count of the number of human interactions that you have in a given period of time. So whether that's a day, a week, or a month. So you can have both of these happening at the same time, but I think it's also important to recognize that you can be around people, as you might be if you live with others, if you're in a residential community, and you can still be lonely. You can be, for instance, a caregiver who lives with the person that they're caring for and still be very lonely, particularly if the person's not able to engage with you. These overlap, as you'll see. So what do we know about loneliness? Well, it's been around a long time in the literature, not terribly well known as a field of study, to be quite honest. It was first mentioned in the 60s. Vivek Murthy, who's a former US Surgeon General and recent appointee to the Biden, President-elect Biden, of course, his COVID task force. And he began to raise awareness about this issue a number of years ago. And in 2017, he referred to it as a global health epidemic. And then the National Academies of Science, Engineering, and Medicine put out a major study in February of this year, so right before COVID, and referred to loneliness and social isolation as a public health concern. So there's been increasing awareness of it. I do want to draw your attention here up in the left-hand corner of the screen. Murthy has just published a book that came out, and it actually speaks to these issues. The entire book is about the healing power of human connections and really addresses issues of loneliness. He was also quoted, if you look at the bottom of the screen, I think this is such a profound statement. During my years caring for patients, The most common pathology I saw was not heart disease or diabetes, it was loneliness. And so I think this is an issue that most of us probably have not given a lot of thought to, unless we're experiencing it or know someone who is. In part, I think we don't talk about it as a society because there's stigma attached to it. And I think by us being all here together today and being willing to address it, I think we can begin to lessen the stigma and eradicate, in fact, the stigma. So we know that loneliness is more prevalent among all age groups, and our average network size has been on the decrease. You can see here in 2006, there was a study that showed that it went from each of us having approximately 2.94 persons in our network down to 2.08. Cigna, which is a major healthcare insurance company, did the largest to date study of cross-section of US adults. And just, if you will, scan these bullet points here very quickly, these numbers are staggering and appalling. Again, I think it just serves to raise our awareness. So nearly half of people say they sometimes or always feel lonely. This is across all age groups. And comparable numbers say they feel left out, and slightly less, but still impressive numbers say they have relationships that don't have meaning and they feel isolated. About a quarter of people say they don't feel like they're understood by others or have people to talk to. On a more positive note, over half say they do have meaningful daily in-person interactions. Those who live with others do tend to feel less lonely, but single parents say they often feel more lonely. And this last one, please take note of this. The Gen Z generation, the 18 to 22-year-olds, and heavy social media users are reported to be the loneliest and least healthy. And I think that's an appalling statistic that I hope as a society we can begin to address. So what do we know about loneliness in older adults? Well, the prevalence rates, as you can see here, are just all over the place. And that really speaks to the way the information is gathered. It depends on who you ask, when you ask people, and how you're assessing it or the measures that you use. Generally, the prevailing thought is it's somewhere between a quarter and a third of older adults, specifically in the US, say that they are significantly lonely. But as you can see here, those numbers also go all the way up to almost 60%. And again, I think it really depends on who you're asking and when. We do know with absolute certainty that the issues of loneliness and social isolation are underassessed by healthcare providers. And if we were in person, I'd ask for a show of hands about how many of you have ever been asked by a healthcare provider if you were lonely or socially isolated. And I would be surprised if there were many hands that went up. Maybe now during the pandemic, healthcare providers are becoming more aware of this issue and are maybe asking, and again, I hope they just don't forget. So we do know that the two issues, as I mentioned earlier, are linked. And enough research has been done to begin to identify risk factors. We know being isolated from people increases the prospect of being lonely. We know that people who live alone and those who are unmarried or unpartnered. But again, it's important to remember you can be lonely with people, but not necessarily lonely if you're alone. So those make it an even more complex issue. So in terms of social isolation, the research has shown that it places us at greater risk for having cognitive impairment. We know that those older adults who are socially isolated tend to be more stressed. They tend to have less access and use of social resources and have impaired sleep. And again, risk factors, being unmarried, unpartnered, being male, and then having low levels of education and income. And these last two really probably speak more to one's ability to access social resources. And this final bullet point at the bottom, again, a staggering number. Medicare estimates that they spend approximately $6.5 billion a year in increased hospital stays, and an outlay of healthcare expenses because community support is often lacking. And again, we just need to keep on top of this. So predictors. You can see there's a lengthy list here of predictors, from living in a rural area to having poor functional status with IADLs and ADLs, being unmarried, unpartnered, particularly if someone has been widowed or lost a partner in recent years, being female, which may, as it indicates here, be due to different expectations for relationships, that lower income and education again, and then really losses. But the four that I want to draw your attention to are the four that are most statistically significant in the studies that have been done. So those experiencing depression, again, this living alone piece, feeling poorly understood by others, and being a member of the LGBTQ plus older adult community. These are stronger predictors than health, functional status, or even widowhood. Living in residential care can place one at particularly high risk for loneliness. The numbers have been out there for some years that indicate that people who live in residential care, particularly skilled care, can experience this. But there's a study that just came out this year that surveyed several skilled care facilities and found that 100% of the residents who responded indicated that they were lonely. 75% of those indicated that they were severely lonely. We've begun to collect data here in the St. Louis area. We have one skilled care facility we've been working with, and we found so we collected this data back in 19, we found that about 10% of the residents of this particular skilled care facility were extremely lonely. And this is a particular facility that has probably a higher than usual rate of activities. They've made a very concerted effort for decades to offer stimulating and meaningful activities to the residents. So if you can think about that in that context, they still have 10% of those older adults who are reporting that they are feeling extreme and severe loneliness. Which, of course, as we know, goes without saying that has been greatly exacerbated during this, this period that we're living in. So speaking of social isolation, link again to the increased risk. And oops, I'm sorry, I went in the wrong direction. My apologies. I thought, wait a minute, I think I've already said those things. So we're going to do a poll here. And if you were, I included this poll in the September talk. So let's see if folks remember from that one, if you participated then. But please enter in the poll when it comes up. Do you think loneliness is a greater health danger than cancer, cardiac disease, obesity, or substance abuse? I think Carmelia will give us a minute. Cardiac disease appears to be winning out. Okay, so it looks as though 20% of you thought that loneliness is a greater health danger than cancer. 56% opt for cardiac disease. 15% indicate obesity. And in fourth place, 8% for substance abuse. Okay, stay tuned because I will provide the answer here momentarily. All right. So we know the impact of loneliness and social isolation, both, particularly if they're chronic. have major impacts on older adults in 3 areas specific: physical health, mental health, and the utilization of healthcare services. These are what you see here on this slide is not an exhaustive list. I don't have enough slides or space to indicate all of the impacts, but these are the most significant ones. So let's start over on the left-hand side looking at physical health. We know that loneliness impacts blood pressure. I've already mentioned depression, weight gain, smoking, substance abuse, and certainly alone time. We know that it also co-occurs with frailty, and you think about as someone experiences any kind of chronic physical health problem, they often tend to withdraw, which sort of becomes then a vicious cycle. And here's the answer to the polling question. Loneliness is more dangerous than obesity and as damaging to health as smoking 15 cigarettes a day. Not to have these be scare tactics by any means, but I think these are 2 particularly significant findings, and ones that we already know, which is such a well-known piece of knowledge in our society, that both obesity and smoking cigarettes are bad for your health. But I really question how many of us ever were able to connect that to loneliness and or social isolation.
Marla, you've gone muted.
I just got a message saying the host muted me. So I just unmuted myself. I've never had that one happen before. The joys of webinars. But thank you for letting me know. Increased mental health challenges. Again, depression appears here, stress, certainly, as I've mentioned. And then there's this issue that I alluded to earlier, impaired cognition. And there's a study that just came out a few months ago, and it's probably the most telling and the most sort of definitive to date. There is a 40% increased risk of experiencing all-cause dementia if one is experiencing chronic loneliness. And then from the healthcare service standpoint, I kind of alluded based on the Medicare spending data that there is increases by 50% in use of emergency services, and then greater than 12 primary care physician provider appointments per year. And I think probably most of us, particularly who work in healthcare, you know, we've seen those patients and clients who come in on a very frequent basis. In some respects, it's a twofold issue. People who are chronically lonely or socially isolated, as we know from what I've just shared, are experiencing.
It's okay. I'm on a Zoom.
Are experiencing physical and mental health issues. We know that, but the healthcare system can often become a social outlet. And in fact, people will even indicate that that's one of the strongest connections that they may have in their lives. Sadly, we also know that people who are lonely and chronically socially isolated tend to end up being institutionalized more frequently and end up in skilled care facilities. And that's, you know, these are all issues that we kind of have to all be aware of as we work with older adults. So Steve Cole at UCLA, I thought did a really nice description of being able to better understand the impact of loneliness and social isolation on the body. Loneliness acts as a fertilizer for other diseases. The biology of loneliness can accelerate the buildup of plaque in the arteries, help cancer cells grow and spread, and promote inflammation of the brain. Loneliness promotes several different kinds of wear and tear on the body. And again, I suspect for many of us, this is new information because we've just never really thought about you know, these issues having an impact. So Holt Lundstad, who is one of the premier researchers in the US for these issues did a significant study where they looked at data of 3.4 million persons over a 7-year period who reported that they were in fact experiencing loneliness and social isolation, or they lived alone. And here's what they found. 32% of those had an increased risk for death if they lived alone, 29% if they were socially isolated, and 26% if they were feeling lonely. So the way that Holstad and her colleagues describe this phenomenon is, if you kind of start at the top of this graphic with the circle, loneliness inflames the brain's white blood cells. Kind of Cole alluded to that a little bit in that quote I just read you. And that makes you then feel irritable, suspicious, negative, fearful. Your brain misreads signals, people become threats, they become annoying at the very least, and then your reality becomes somewhat distorted. We then tend to withdraw even more. And the more we withdraw, the more we are lonely and socially isolated. So let's look at assessment, and particularly in light of the fact that I said we know with complete certainty that it's an underassessed issue. And I want to share with you a few things, and then I will turn it over to Max. So there's a variety of ways to come at the assessment issues. And there's standardized measures. I'm going to share some of those with you. You can certainly ask single item questions, or you can do kind of a head-on and just ask people, are you lonely? And how many people do you interact with in a daily, weekly time period? Interestingly, we know two things that make assessment particularly challenging in some ways, kind of thing to incorporate into your practices. We know that all age groups overestimate the prevalence of loneliness in older adults, but older adults don't necessarily overestimate it. So I think that we just have to kind of keep that in mind, because not everyone that we ask will be lonely, obviously. So the other interesting thing is that women respond differently when asked about being lonely. They're more likely to be open and transparent about this if you just ask directly, whereas males will tend to be more forthcoming if you ask them scaled questions or use some kind of measurement tool or instrument. So again, know your populations and know your individual clients and patients. So ways that you can address the assessment issues using standardized measures. Certainly, because of the linkages that have been well established between depression and anxiety and loneliness and social isolation, you can get a hint about this by just asking about mood and using standardized measures for that, which may already be part of your practice. I always want to make sure people do incorporate the anxiety piece, because being lonely and socially isolated, because they're such complex issues, often make people, as I've talked about, more anxious. You can also look at it from the standpoint of what kind of social support does the person perceive that they have. And then certainly there's some nice, well-established, validated tools to assess loneliness directly, but also don't forget the linkages that I've talked about to physical health. And then there's qualitative and open-ended questions that can just really more conversationally help you to get at that and looking at the context. And I think, in terms of thinking about the context people are having, particularly right now during this period, I think we have to expand a little bit beyond those in-person contacts. And we have to be thinking now about, what kind of contact. I mean, certainly we know there are older adults who go for days on end with no human contact outside of themselves. And so I think we have to be looking at both phone, online kind of contacts. So some sample questions. Tell me about your daily life and routine. Tell me about your life overall. What do you think about loneliness? Are you lonely? Tell me about your interests. That tells you a lot about people and how they spend their time. I like this one. If you have good news or exciting news, who would you call first? And then asking certainly, how often do you see family? I'd include friends in that as well. And tell me about relationships that you have with family and friends. These are much possibly more conversational, but maybe less threatening ways to address the issues with older adults. Because do remember, both of these issues can really be perceived by all of us as being very stigmatizing, that there must be something wrong with me if I'm lonely. There's something wrong with me if I'm isolated, because that means other people don't want to be around me. That, and we all know that is not necessarily the case, but I think that certainly fuels the fire for this being stigmatized. If you have other suggestions, I'm always looking to expand this list, so put those in the chat box if you would, and we'll look in on those in a bit. So if you have the luxury of time to do a full-on comprehensive assessment of these issues, which, all of these measures that you're seeing on the screen now are ones that, with the exception of the loneliness one, are ones that quite honestly should be done within a healthcare setting, and even potentially in a social service setting as well. But I recognize the reality of practice may not afford you the opportunity to have plenty of time to do all of these measures, but did want to share them with you because I think they're all ways to get at the issue. So certainly we want to have a baseline for understanding the person's cognitive function. And I'm going to actually, I've got screenshots of each of these measures, but I'll just kind of quickly tell you here, and then we'll look at each one individually. So depression and anxiety, again, because of the strong statistical linkages to those. And I'll talk about ways to get at that. Social support, I'll share with you a well-respected measure. I've got we'll talk about a loneliness scale, and then the mobility issue. Mobility is an important issue because, again, it can create this cascading effect of, if someone's lonely, they're spending more time potentially alone. And if you kind of layer social isolation on that, we become more sedentary. They may not be getting up and are active. And this mobility cascade of muscle weakness and frailty then can kind of just over people. And it's much more challenging to sort of come back from that. So the rapid cognitive.
Marla, we have
Yes.
a question.
Oh, great. Thank you.
Are there any stats on persons that have the opportunity to engage but choose to stay lonely? And how do we assist those people?
That's an excellent question. Thank you for whoever. Yes, there is. And that's a good reminder for me that I should include that as part of the training here. Yes, so there's some recent work that has just come out that said there are those people who prefer to be alone. And they may or may not actually be lonely. It's not a given that those who prefer to be alone. So I think the important piece about that is you need, with that individual or that group, you need to determine, is this someone who chooses this? Or is this someone who's come into being lonely or socially isolated because of these other issues that I've already talked about? So find out what the motivation is, what's the source of their situation, and as a way to explain it. And then to ask them, what do you need? And I have this on a slide later. What do you need? What do you want? And what are you able and willing to do? So I think then you get at that. Sometimes if you can kind of dive a little bit deeper into the issues, you'll find that people have, and I mentioned this earlier, they feel as though they're not being well understood by others. That could quite likely be a lifelong issue, and that if you can get them to be forthcoming, they may have always felt lonely. Or is this something more recent, that they're maybe not well understood by others if as they've aged, as they have maybe developed some sensory impairments, for instance, That can be a significant issue in not feeling like others are relating to you, if you can't see them well, if you can't hear well. So I think you have to get at the root of why is someone appearing to want to be alone, and then you kind of use your best judgment to move forward with that. And maybe this is the person, for instance, that you would not recommend a group intervention like Circle of Friends. But in fact, what you might suggest to the person is that they could benefit from possibly a behavioral cognitive approach in a therapeutic relationship. So I hope that answers the person's question. Thank you. That's an excellent one to address. So Danielle, are there any more questions before I go on?
No, there are no other questions at this time.
Okay, great, thanks. Please keep the questions coming. So we want to assess cognition. Some of you may be familiar with the St. Louis University Mental Status Exam. The rapid cognitive screen that you see here is the validated shortened version of that. And it's 4 simple questions. They can be asked over the phone. They can be asked over Zoom, over telehealth, with one exception. You have to make an adaptation. If you see question number 2, it's a clock drawing, and I'm sure many of you are familiar with clock drawings. And you have to get creative in the ways that you think about getting the clock drawing. We run a free geriatric assessment clinic through SLU, and we're doing it via telehealth now. And so we have the very high-tech version of the clock drawing. We have the person draw it and hold it up to the screen so we can see it. Clock drawings are fascinating and tell us so much about executive function of the brain. But you can get a sense of where people are just from these 4 questions, whether cognition is normal, mild cognitive impairment, or dementia. So the PHQ-2 and the PHQ-9, I think most of us are familiar with those as standardized depression measures. They're from the CDC and are available for use and are really good. The PHQ-2 is very much a screening tool. And if the person indicates that they are in fact experiencing depression with a score of greater than 2, you would want then to go on to the PHQ-9, which is 9 items. It goes a little bit more in depth and certainly can let you know. And the question, as it relates to this loneliness and social isolation issue is, it's a chicken egg kind of issue, to be honest. Are they depressed because they're lonely or socially isolated, or are they? Is it the opposite? So, but again, I think you have to have all the information if you have the ability to gather all of this. I mentioned the anxiety piece. This is the sort of the gold standard, if you will, to assess anxiety in older adults. It's called the Generalized Anxiety Scale. Very simple administration, very simple scoring, and can certainly let you know whether the person is mild, moderate, or severe. And this is a tool that's easily available for anyone's use. The Lubin Social Support Scale, there's several versions of it. This is thankfully the shortest of the versions, and is a little bit more detailed and a little bit more cumbersome, to be honest, to administer. But I think it can give you just a wealth of information about the older adult. Who's in their network, what kind of relationships, how frequent are the contacts? You can see here just from the questions, how do family and friends kind of compare to one another? There's the 6 items here, and the scoring certainly indicates whether or not the person is at risk for social isolation. The UCLA loneliness scale, again, if you just Google it, you'll find multiple versions of it. This is the revised version, still long, still lengthy, 20 items, but is considered to be a well-respected, well psychometrically validated. It's also been validated on both younger and older adults. So and that's important in terms of the effectiveness of a scale, is that it's been validated on the population that you're using it with. I do want to just share with you a new tool that we developed at St. Louis University called the Alone Scale, using the mnemonic alone. And and I've got to remember in these slides to add the word emotionally, because automatically people think physically attractive, and that's not what that first item is intended to indicate. Are you emotionally attractive to others as a friend? Yes, sometimes, or no. Are you lonely? Are you outgoing and friendly? Do you feel you have no friends? And are you emotionally upset or sad? Because this is a new tool, like the others, it is not psychometrically validated yet. We're in the process of doing that, and would welcome anyone adopting it and giving us some feedback about how it's used. I think generally, because it's not validated, we don't have a specific scoring system developed for it yet, but I think you can use your good practice judgment. And if someone, for instance, responds positively to 3 of the items, I think you certainly have an indicator. With all tools, want to add this sort of caveat or disclaimer that any tool you use, particularly the ones I've indicated here, these are screening tools. And, for instance, with the depression scale, the anxiety, those have basis in physical functioning and potentially physical disease. So you want to make sure that you encourage people to seek out their primary care providers to get further assessment. And that's one's also very true for the SARC-F. So the SARC-F looks for sarcopenia, or loss of muscle, or muscle weakness. And some of that is inevitable as we age, but this actually gets at the heart of one's mobility. And again, we know that mobility issue is linked because it's physical activity. So it also gives us a little bit of insight into if the person has had some falls, if they can't go up or down stairs easily, or even walk across a room. That may give you some tips about whether or not this person is starting to withdraw from their previous activities.
We have a question, Marla.
Great. I was just going to ask that. So what's the question?
From Rick. We are currently using the geriatric depression scale and the Folstein mini mental exam. Are these tools outdated or no longer being used in practice?
No, they are both still being used in practice. They are both validated. I will share a story about how the St. Louis University mental status exam came to be. The Folstein Mini Mental was the gold standard for decades and decades, and not to say that it isn't still. It's a very well validated tool. Max and I have a colleague, Dr. John Morley, who was a friend of Folstein's, and Folstein had shared with Dr. Morley that he would never charge for the tool. Many of the validated tools, as I'm sure everyone knows, you have to pay a fee to use them technically and legally. And so there was a point at which some years ago that Folstein and or his colleagues, not really sure the details of that story, decided to begin to charge for the scale. It's copyrighted, and they were well within their rights to do that. And so Dr. Morley felt very, very strongly about measures not, the people who develop measures not charging for them. So he and a group of people at St. Louis University embarked on the development of the St. Louis University mental status. So all of the measures that we develop through St. Louis U, the Alone Scale will be one of those. The SARC-F is also in that category. It was developed at SLU, and several others have never been and never will be copyrighted, so that they can be used by anyone, anywhere. Now, we do run the risk, of course, that people alter the scales, and that can compromise the integrity and the effectiveness of the tool as a measure. But for the most part, so the St. Louis University mental status exam, which the rapid cognitive screen is drawn, has been validated on 4 continents, and we have it available on our website I think there's 27 different language versions of it on our Geriatric Education Center website, which is aging .slu.edu. Very, very simple address to remember. And no, we are not advocating against the use of the geriatric depression measure or the mini mental. They're both absolutely fine measures to use. They are not necessarily outdated. I've never seen anything to suggest that they are outdated, but I think the important issue here is that you're assessing. And certainly if you are going to assess using a standardized measure, you need to use ones that have been validated on older adults. And certainly those both have been. They were developed for use with older adults. I think there are measures out there that do get used that have not been validated on the population that you're using them on. And then that really does call into question the integrity of the findings that you're having. So I hope that was helpful, probably way more than you ever wanted to know about measure development, but you know, everything has a story. So Danielle, any more questions before we take?
I have a question. I was just wondering, all of the scales that you shared today, are they free to use, or are there fees for using any?
So the rapid cognitive screen, the let's see, you're quizzing me now in terms of, do I remember everything I just said? So everything except the Lubin social support scale and the UCLA are considered to be in the public domain, which means that they are free and available for use. The other two are used widely in practice, and if they're going to be used in research, then you do need to get permission to use them. I am not aware, Max, jump in if you have information counter to this. I don't believe there's a fee for either the Lubin or the UCLA scale, as far as I know.
I haven't heard anything either. I think as long as, yeah, if you're using it for, clinical or research purposes for those reasons directly, it should still be accessible.
Yes, yes.
Marla, I got a question, a quick
Sure.
question. You had mentioned when you spoke about assessment that how to get men to respond, that women were more open and direct. And I teach the healthy living class. We always have more women than men. And one of the male participants said how it was so difficult for him to respond to some of our discussions and that women were more open. Have you done research on how to get men more involved, how to get men to be more open? I think you did mention, but I didn't understand what you said about how to get men to respond or how they respond.
So what I had said earlier was that men will be more forthcoming about loneliness and social isolation if you use one of those standardized measures, or if you just have a questionnaire kind of approach to it, as opposed to just, you know, saying, so do you think you're lonely? Women will be more forthright about how they respond to that. And Max, you know, I want to jump in here. One of the things, and yes, there is some research about that. And more anecdotally, however, we interestingly just had this conversation with the graduate students who are facilitating Circle of Friends through the SLU Memory Clinic. And they were talking about, they have a group that on that particular day was all males. And and the topic of the day was supposed to be to talk about your feelings about being lonely. And so they sort of came at it less directly, as opposed to just, because I think they tried, Max, jump in here if you can add to this, but my recollection of what the students shared was that they'd sort of come at it more directly and then kind of backed off a little bit, and were able to get at more feeling kind of things by asking questions related to related to childhood and life memories. So not quite hitting it as head on. And I think, you know, one of the things that if feelings will come out, those are not always inevitable, but I think feelings will come out. I think you just have to think about the approach. Is it sort of this head on, okay, now we're going to all talk about our feelings, or do you ask questions, prompt discussions that will come out a little bit more indirectly? I don't know, Max, what do you think?
Yeah, no, exactly what I heard too from the group. And I'll say that you can have creative strategies, you know, if you have kind of mixed gender groups around feelings. I mean, a lot of times it's been success around how do you cope with feelings? What activities or solutions do you have to combat loneliness? And then they'll kind of have a go-to strategy or a hobby. And sometimes that brings in male participants a little bit more. But I think it depends. I think, as Marla said, I mean, it's anecdotal based on what we've seen from groups, but we've seen a fair number of men too who have been able to share and express things too. So it's not to say you want to go in with a lens of, you know, who will disclose and what.
Right.
I think every group is different, but yeah.
Okay. All right. Thank you very
If
much.
you have strategies, please, at any point, please send us an email and share those, because I think we could all benefit from having more strategies in our toolkits. So,
Okay.
Neil, are there any more questions?
Thank you.
Get unmuted. No, there are not.
Okay, all right, well, let's take a 10-minute break. So let me see, according, I have 10 o'clock, right on the nose. And let's plan to reconvene at 10:10. Hello, everyone. It's 10:10, so if we can come back together. Before I turn it over to Max, I just wanted to respond to a few things that I read in the chat box while we were on break. First of all, thanks to everyone for putting your disciplines or your professional roles in the chat box when we ask about disciplines. I am really glad to see there, you know, we have a city planner, we have somebody who works in housing, foster grandparent programs, senior centers, wellness programs. As you know, one of the takeaways from all of this work that Max and I are passionate about conveying to people is that this really isn't just a healthcare issue or just a social service issue. To use a way overused cliche, it takes a village to address issues of loneliness and social isolation. So glad to see that there are people here who work not only on the you know, individual family, kind of micro level, but also at the macro or community and organizational level. So thank you for all being here. Few other things. Thanks, Joan, for putting a comment in the chat box about the crackdown of using copyrighted materials. I think that Scale specifically. I think you're absolutely right about that, and so we're starting to see even more kind of a proliferation, if you will, of scales that are being put out there that are not copyrighted. And as I mentioned, there's some risks involved. There was a comment about Zoom, and I think the consensus about the use of video conferencing technology in general is, particularly for many older adults who've not sort of grown up with, if you will, the you know, technology being such a part of their communication lives, you know, I think it's problematic from a literacy standpoint, but the common phrase that I hear used over and over and over again as it relates to any use of technology, it's what we've got now and it's better than nothing. That's not what you want to hear, but I think, and I think some groups, some things will continue on using Zoom. You'll hear from Max. We've been using Zoom to deliver Circle of Friends for some months now at St. Louis U. I think it's really about what meets the needs of your client population. the one thing we cannot ignore, and I'm sure I don't need to say much about it to this group because you're all already very aware of the fact that so many older adults don't have access. And so you have to be creative in ways, you know, phones still work well. Just plain old landlines still work well. The numbers that are coming out that indicate just in general with our population, those that don't have access to Wi-Fi or own a computer are much higher, I suspect, than most of us believe. There was also a comment or a question about marriage and pets. And I think that both of those things help. And I suspect in many ways we see loneliness being less among the people who are married or partnered and that have pets. It does not prevent one in many cases from being socially or from being lonely. Certainly if you're married and partnered, live with the person, you're probably having some social contact, but you can still be experiencing loneliness. So with that, I think I addressed everything that came up. I want to now turn it over to my colleague, Max. I'm very grateful to Max for partnering with me on this adventure and to take the bold step to be the first to offer Circle of Friends through St. Louis University, and certainly the first to offer it virtually. So you'll hear a lot more about the intervention and his experiences as well. So take it away, Max. Thanks.
Thank you, Marla, and ditto for all the support and help at SLU, as well as the connections with Kansas City, and I know those across the Midwest doing this great work. So, all right, I will share my screen here, and hopefully that is up and running. All right. So Marla gave a great background on isolation and loneliness, and just some statistics and kind of the overview framework, which I think is really important, because I think it highlights not only the need from this on a public health standpoint, but also a lot of the correlations and comorbidities that loneliness is starting to have. And as Marla mentioned, we saw in the chat box in the other disciplines with senior centers, wellness, age-friendly careers, nutrition, recreation, professions. That's wonderful that all of you are able to have an interest in this. It's such a critical need. And I think, post-COVID, whenever that may be, or at least the transitioning out to in-person groups again, we're really going to need this from a community level. So all the work that you've been doing around this has been huge, even virtually now. And as Marla says, it takes a village as far as resources that we can have around loneliness. So as this slide says, it's certainly not a one-size-fits-all approach. We've seen that if you're in a circle of friends group, that group looks unique from the next group, and anything else that you do. So we have one participant that's in 4 different groups going on virtually, and she says it's almost like entering a new community of friends based on which group you go in, even virtually, and can't see everyone in person. So certainly this has enormous benefit for everyone. So we'll start out just talking about some community level, the importance of multidisciplinary work that we're still doing around social isolation. So increasing professionals regarding the impacts of isolation, and especially in marginalized populations. Certainly we see this in St. Louis, I'm sure in Kansas City, other urban areas as well around the country. This is becoming really difficult to find populations and areas where those that are underserved can find meaningful interventions of being lonely and homebound. There's a lot of health disparities and social determinants that are really impacting communities. And so that's been a big area we've been trying to address in St. Louis, not only in our Circle of Friends grant, but just in research that we're doing. Around the interprofessional multi-systemic approach, collaborate, collaborate, collaborate. That's what we're really learning on all levels. And I'm sure many of you that have uh, referrals and resources during this time, we've gotten so many different referrals around our loneliness groups and Circle of Friends protocols that we've been doing, whether it's from providers, from community agencies, from other memory clinics, geriatricians. We all have to really work together to make sure that we're addressing this, and that there's evidence for this as well too, that we're utilizing services and that we're measuring isolation the way we need to. Marla made the point earlier around medical professionals addressing this, and what we're doing in our primary care clinics is seeing if our family docs can ask one question for someone 65 and older around loneliness. Do you feel lonely, or if you're not depressed, do you still feel at all isolated from family or friends, and is that impacting your life in any way? You'll find a much different answer if medical professionals ask that versus are you depressed or not. People are a little bit skeptical as far as being able to report being depressed. So loneliness is kind of that gray area, which again, I think we can really hit on. We also have to develop a lot of tailored interventions towards loneliness. I think to answer that question in the chat box, again, it's very preliminary to see if virtual interventions work. Anecdotally, we've seen that we've had a lot of success in our groups at our clinic, and I'm sure out there, just the connections for people to have that they normally wouldn't in person makes a huge, huge difference. The middle bar talks about interventions that can be adapted across loneliness. Again, physical activity, lifestyle adaptation, nutrition, health education. These need to really be incorporated in groups. Again, when the Circle of Friends protocol I'll talk about addresses physical activity and really being active, as well as ways to eat healthier during COVID, getting information from different places, really makes a difference to curb these loneliness trends. And planning for social connections. So again, what are the obstacles and challenges that maybe your population you have needs to overcome that? Mentioned before was issues of technology that we see in the community, but also people just don't have enough transportation or family or friends to get people to places. Maybe they're in a community where there's higher crime rates or things are unsafe. Maybe they don't have as many neighbors to help them. So how are we addressing some of these challenges of not only people living in place in their home, but also if they want to get out in their community and be active still during the pandemic? So there's a lot of these issues we have to address not only from a bigger level, but when you're starting a group itself. So some of the interventions we mentioned that are tailored towards this. Again, there's promising results that we're starting to see. A lot of the earlier research done 15, 20, 25 years ago touched on interventions for loneliness, but again, it wasn't really a standardized protocol like Circle of Friends or things that we're trying to do intentionally here. So the effective skills that are mentioned here, physical activity, cognitive stimulation, ways that facilitators can empower people through group connection, promoting more interactions, not only during the Circle of Friends group, but afterwards, really makes a huge difference. And I love the quote from Philip Rosario. Idea of people wanting to age in place sometimes ends up with them aging in isolation. We have to look for ways which people can age in more of a connected fashion. And there's a commitment from us as a society to do that. I think that is such a timely quote during COVID, and the aging and isolation area really is hitting home for a lot of our older adults. So a little bit of a busy slide, but just talks about different protocols, and more so on the blue column, where's your entry point and how you're trying to address isolation or homebound seniors. Are you doing more engagement, more impactful approaches, or more sustaining approaches? And again, I think it always is based on the type of protocols that you want to do. I think a blend of these is really important. And the ways that you try to not only recruit people for interventions and support groups, but how you connect, especially during the pandemic. it was a lot easier maybe for us to do the middle part with impacting, where we're doing proactive, more door-to-door or phone calls or even home visits to try to reach out around people who are isolated. Now, if that's more of a barrier, we have to work on more of an engaging public health population-based approach to connect with people, to do more virtual visits, to use more community resources to really address seniors who are isolated. So wherever you kind of work on your entry point is really important. And I think during the pandemic and even months afterwards, it's going to be important to know how we're reaching as many people as we can and really being creative. I think that's one of the big things that we're trying to address here and work on. So as far as what gerontological practitioners can do during this, and it's not only geriatricians and geriatric social work and other people specialized towards this. I think everyone in the community working together on this. We really have to address health issues and again, other lifestyle management things that are impacting loneliness and isolation. Certainly identifying risks of depression. So again, the crossover is that people who meet a major depressive disorder are most likely lonely or isolated in some fashion. But people who are lonely don't necessarily meet a diagnosis of major depression. So that's something you have to know that scale on. Usually people who are lonely can still want to be engaged. And again, find social connections. They may not necessarily have the means to do that. But what we're also seeing, and especially in our cognitive stimulation groups, is those with some sort of mild to moderate memory loss. When people are lonely or isolated, their memory does get worse. So we've been finding a very, very strong correlation in our CST groups around loneliness and higher rates of depression and cognitive decline. That's a really big issue and something that needs to be researched a lot more. So as far as strategies that we're looking on, more comprehensive geriatric assessments and screenings. We do a little bit of that at our geriatric assessment clinic at SLU, where we have 6-7 different professional areas looking at ways to help families combat loneliness or memory loss or other health issues. Regular monitoring of patients' needs, I think, is very important too. I always like to call it either a pull or a push intervention. So when we have pull interventions, normally where patients come to us, right, we're providing services in our office, in our clinic. The push intervention during COVID and a pandemic, when people can't come here, is how do we push out to the community? How do we use resources so that we're broadly based, sending stuff to people, and so that they can receive that in their home if they can't get out much? So that's a very, very important thing that we have to realize, is just as much push as pull really has to happen for people who are homebound and isolated. And then the bottom point is really recognizing from caregivers and family members, really being involved in the treatment process and what's called social prescribing, so that we're making treatment plans and prescriptions of interventions that's social and family based, not just individual based, because caregivers and loved ones have really been the key players and wild cards here as far as getting people better and connected with services, getting them onboarded with technology, so on and so forth. And we also have to address the community roles as well as some of the other cultural factors that are coming into play as well too. We found that a lot of people entering the virtual circle of friends have far different experiences in their community, their neighbors who can help, people they have to get them out and maybe, take walks or again, transport them to visits. So these social isolating practices that people have are forming either really positive or really negative effects on the routines. So one thing we try to do in Circle of Friends, not only coping strategies or ways to combat loneliness, is how can you kind of break those patterns and routines of loneliness and kind of do one thing different this week. Even if it's only one thing, it breaks that pattern and it breaks that cycle. We also have to find a lot of things within our research and what we do clinically. And I think the top point, that stigma, it certainly exists. And I think that's one of the great things that Circle of Friends does. It eliminates stigma of people being able to be vulnerable to say, I'm lonely, I'm isolated, my family's not helping much. I'm really coming to you with, just a lot of insecurities about it. And this group is helping me feel more secure. So even if that's one of the main goals in your group, it's such a huge breakthrough for many people. And obviously, we need to promote more best practices and more of these group interventions to combat social isolation, which I know is a no-brainer for all of us, given this population that we're working with. We already have a gentleman in our circle of friends group who was really quiet at the beginning and then kind of came to life in the last couple sessions. And I think he mentioned somewhere between saying, I'm starting to really like this group. It's kind of growing on me a little bit. And just that statement alone, you would have never predicted 8 weeks ago, 9 weeks ago that you would have mentioned this. So just even a positive perspective with other adults makes a huge, huge difference in people's lives. We also have to know the areas such as ageism and some of these post-COVID areas that we're kind of coming out of, and kind of just running down the short list here. And I mentioned before, health disparities certainly exist, unfortunately, not only around COVID rates, but especially around how we're addressing homebound seniors in the community. One of our partners, St. Louis Housing Authority, does an amazing job getting tablets, phones, different sources of technology out to their residents. It is truly a organic grassroots effort in communities to get this out to the public when you're working with people in different sections of St. Louis. So, and for us to really know that when we get to post-COVID and we're getting back in public, how much are we going to have more of social engagement versus continued loneliness? I tell a lot of people, on these talks, even locally in St. Louis, the loneliness epidemic's not going to cure once we find vaccines. It's going to help us as far as public health and certainly us feeling more comfortable to be out there and prevent the risk of COVID, but the risk of isolation and just in people's minds from a routine standpoint, I think it's going to be a lot more difficult for seniors to kind of get out of that mindset and routine. Now, I could be wrong, but I think a lot of people said they want to stay on virtually. They're still unsure, even in much of 2021. So I think the jury's still out on that. But knowing also that technology for the meantime can really be a good tool and ways to connect with people, I think is really important. And mostly at the bottom point, self-care, not only for people who are isolated, but for caregivers as well. And even I'll throw in the providers too. We've been trying to address compassion fatigue for our providers, not only on the front lines, but also in nursing homes, assisted living facilities, in community agencies. We're working tirelessly, all of us are, to try to find ways to reach every single person that we can. So it's really, really difficult and tough to really address all of this. All right, so now we'll get into the nuts and bolts of Circle of Friends. As Kaisu Pikala, one of the founders of the intervention in Finland, said, it's not the activities or the leader itself when you're running groups, Circle of Friends, it's peer support, group dynamics, and cohesion. So one thing that we'll stress throughout the talk today is this is really a participant-led group. And if you're used to being more of a director, a therapist, a top-down approach person, you'll have to shift the hat that you're wearing in the group to being much more of a facilitator and co-experience led group with it, which I think is one of the great things about Circle of Friends that it offers there as well. So what is Circle of Friends? Before we get into the definition here, I will play one of the videos from Finland. There's English captions. I don't expect all of you to be fluent in Finnish. So the English version will be down there. I'll also show the website before we get to break so you can see that there's more videos and things on there. So if the audio doesn't work, just let me know. But in the meantime, I will play it here.
Mun poikani kuoli, mun ainoa poikani yli 50-vuotiaana. Ja siis se, että mulla ei oikeastaan ollut muuta perhettä, niin sehän se vaikea olikin.
No yllättäen sillä tavoin tuli, että kun syöpä vei vaimon, niin sen jälkeen mä olin yksinäinen.
Kaikki ihmisethän kokee aika ajoin yksinäisyyttä, mutta ikäihmisillä se on erityisen yleistä.
Esimerkiksi eläkkeelle jääminen, leskeytyminen, sairastuminen tai esimerkiksi kunnon heikkeneminen voi aiheuttaa yksinäisyyttä.
Noin 5-10% ikäihmisistä kärsii yksinäisyydestä jatkuvasti ja noin 30-35% vähintään toisinaan. Ystäväpiiritoiminta kehitettiin toistakymmentä vuotta sitten Vanhustyön keskusliiton geriatrisen kuntoutuksen hankkeen yhteydessä.
Ystäväpiirimalli on yksinäisyyttä kokeville iäkkäille ihmisille suunnattu ryhmämalli, jonka tavoitteena on se, että heidän yksinäisyys lieventyisi tavattuaan toisiaan ja oltuaan siinä ryhmässä yhdessä ohjaajien luotsaamana.
Vanhempanakin vielä pitää olla siis valmis niin kuin tutustumaan uusiin ihmisiin. Ja siis että se, että ei tarvitse kuvitella, että tulee niin kuin ylimpiä ystäviä, mutta se juttu seuraa, kaipaa siis itse kukin.
No siinä rupatellaan ajankohtaisista asioista
ja paljon saa niin kuin itse vaikuttaa, että mitä tehdään. Ja
me tavataan tuolla kahviossa aina ja sitten tätä maailmaa parannetaan.
Päivitetään niin kuin elämää tavallaan noin laajassa mitassa.
Mehän puhutaan vaikka viikon syömättä esiin.
Sinne voi tulla kyllä ihan omana itsenään, että siellä on erilaisia ihmisiä.
Siellä ollaan niin kuin samassa veneessä niin sanotusti.
Homma on luistanut kyllä minun mielestä loistavasti.
Noin 60% ryhmistä jatkaa yhteydenpitoa tai kokoontumisia ohjatun ryhmän jälkeen.
Ikä on oikeastaan se, mikä meitä kaikkein eniten yhdistää.
Mikäli olet kiinnostunut ystäväpiiritoiminnasta, voit saada lisätietoja puhelimitse tai verkkosivuiltamme.
Okay, so we'll pause it there. So I think it's a great video and snapshot of what's available and out there. When we had an initial conversation with Anna and Kaisu way back, I know they had mentioned and said, yeah, all the adults in our groups are able to get together. And I know I was thinking, gosh, it's so cold in Finland. How do they get together? And they said, if we can get it done in Finland during the dead of winter and, you know, below 0 temperatures, it can happen anywhere. So they are extremely resilient, and we'll cover a little bit of the research there too on the 10-year plus groups that have happened out there as well. So it's certainly an incredible thing that they've been doing there. So the Circle of Friends protocol, again, you saw a few of the Finland clinicians or researchers in the video. It was developed out of Helsinki University in the early 2000s. They did a few randomized controlled trial studies looking at the effectiveness of Circle of Friends versus control group, found very good results. We'll show you that later on. So the real aim of Circle of Friends is to alleviate and prevent loneliness. Very, very simple aims. I think the complexity comes certainly in you know, how you're flexible in the groups and making that happen. The average number is about 8 per group. We have right now kind of in our groups that we recruit initially between 5 to 7. We feel that's been a pretty good spot virtually for several reasons. You don't want too many in a group because you won't have enough to check in. But I think also what you can handle virtually is a little bit different than in person. Meets 12 times over 3 months. So it's once a week for approximately an hour. And we'll go over again the protocol when you get to the end of the Circle of Friends 12 session protocol and sustainability and maintenance, which is a great hallmark trait of this intervention. So for participants, really the goal is you get out of sessions to make new friends, to stay socially connected, to feel less lonely, to do meaningful things together. And even now, if it's virtual, we've heard a lot of neat activities that people have been sharing and been able to do together, with family, with friends, even take part in another online group as a result of Circle of Friends. And really being self-supportive and encouraging. This is such a difficult time for older adults, really maintaining ways to connect with people. And I think the fascinating thing that groups have been seeing is where they normally may not make friends in public with people virtually, they really lock in with people. And it takes a few sessions, but as the group goes along, this really becomes a lifeline for them. So it's really incredible to see how 5 or 6 strangers can meet virtually for now doing this group. And it's a group-based goal-oriented intervention where, again, the participants are the ones that are really driving the group intervention itself. As I mentioned, the randomized controlled trial was done a little over a decade ago. 97% survival rate in these groups across time. They've not only mentioned decreased rates of loneliness, but also increased objective health and also reductions in hospitalizations. There's some really, really key outcomes here, not only on a psychosocial level, but on a biomedical and health level as well too. Only a 2.5% dropout rate. Gosh, if we had that in mental health in the US, that would, we would be a game changer, quite a bit more funding. So obviously they're doing something right with the intervention and protocol, but I think for how complex sometimes we make interventions in healthcare, knowing the needs and connections sometimes can, produce the lowest dropout rates for any types of interventions too. On the other study with 117 community people who took part, we reported no more loneliness was almost 100%. Between 45 to 85% made new friends, and almost half continued meeting after the groups were completed. Obviously, some people have scheduling health issues, family needs as well too. But they've also found long-term improved cognition. That to me is a huge, huge benefit as compared to other cholinesterase drugs or medications prescribed for dementia. So again, we're seeing crossover with cognition and loneliness being a very, very interesting correlation, which I know at SLU we're certainly interested about. And I know Dr. Morley's mentioned kind of that crossover too as being important. So why does it work? And more so how it works, we'll get to. Again, the positivity of the group and consistent improvement and process evaluation between sessions is really the core thing. So for those who may be starting out with groups or wanting to, what we've really seen is checking in a lot helps, and being able to get continuous feedback within the facilitators, what's working well, what was a little more of a challenge, what do we need to tweak a little bit more. So if you're doing a Circle of Friends group, never wait until 2/3 of the group to really check in and fight some challenges later on. If you find stuff that you need to alter, this protocol really lends itself to it, as well as being able to interview some of the not only participants, but family members afterwards. What was successful about this? What would help expand this further along too. So this is just as much a pay it forward group, because again, it's areas, not only cognition, but also immune disorders and other blood disorders, chronic health issues as well too. There's some more research that's actually coming out in that some of the biomedical journals, as well as helping people with neural pathways and cognitive stimulation as well too. We mentioned before, promotes engagement in the community. There's also low dropout rates. That's facilitator mentored and really encourages membership and engagement taking place there. This is another busy slide, but really the key from this to take away, these three key areas: social isolation, feelings of loneliness, and a group rehabilitation model, because that's really where Circle of Friends comes out of, is a rehabilitation protocol and theory that people can get better through social connections and social networks, not only improving their mental health, but physical health as well. If you're able to have this framework, you're then able to hit these areas within the red circle here of people feeling more mastery, self-awareness, not feeling like an outsider, feeling their needs are met, not having as much negative feelings. And as a result of that, the long-term outcomes of better psychological health, quality of life, cognitive functioning, depression, so on and so forth. So if you kind of think of this as a timeline process, have this framework of mind for the goals of the group. These are the skills. This is the long-term outcome of health benefits that people have. You'll really see that. Certainly, if you have a much longer study or group, I should say, 6 months, a year, 2 years down the road, you're going to get and see more of those health outcomes just because it's been lasting longer. But I think if you have that framework, it really, really helps. And again, you'll see some really positive results from your group.
Max, we have a couple of questions.
Yeah.
One is, how long does a facilitator usually stay with the group? And because you keep saying that it's participant-led group.
Right. Yep. And the structure and the protocol, we'll talk about maintenance a little bit later. The facilitators stay with the group all 12 sessions. And we suggest having at least 2 facilitators per group there for many reasons. When I get to personalities of group members too and dynamics, but 2 facilitators should be through the 12 sessions. And then during the maintenance part where the participants then co-lead their group going further, they can invite the facilitators back into their group. So it's kind of handing the baton off to 1 or 2 champions of the group that you feel can help co-lead, whether it's virtual or in person. They've been able to go to parks, community centers, different visits, or just meet for coffee.
Okay. And the next question is, any research on personalities of people who join groups? And have you used something like the UCLA or the Lubin as a pre-assessment tool?
Yep. We are using both of those in our groups right now. Yep, the UCLA and the Lubin we're using to assess. Oh, there we go. We're assessing that for pre and post, the UCLA and the Lubin within our groups right now. So yeah, we're hoping to longitudinally see if the groups continue to maybe track 3 months or 6 months down the road to see if there's any impact on that as well. Personalities, as far as I don't know if they meant as far as like research or trying to track anything around there, or anything outside of loneliness or social connection. Those are kind of the 2 main core areas we look to track and research. Now, as far as people's changes in mood goes, qualitative data we get as well too. We get feedback. So again, those interviews that you get throughout the groups and then a post interview, how people are able to change and shape their behaviors, we certainly want to get qualitative feedback. Hopefully that addressed that question the person had, but certainly open if people have had other success with groups or ideas, we're always open to it. But
all right, that's it for the questions right now.
Thanks. Yeah, feel free to keep the questions coming. So like we said, we want to know too what's working well with groups as far as tracking it and what's been out there, and things that we can always implement, because it takes a village. I mentioned the 10-year follow-up study. That was Anna Jensen's study out there, and 2/3 continue to meet following the facilitator-led groups. So again, with that question around maintenance, you know, you have to kind of prep the champions and the point people that you really feel could be leaders, talk to them one-to-one and say, you know, if this group wants to meet, certainly it's up to the group. Would you be able to think of some ideas and prep for that early on? And we'll talk about that too. And they can have strategic ways, but I think the group has to have buy-in and enough of the group to maintain that over time. But as you mentioned, very high rates of no longer feeling lonely. 70% reported finding new friends compared with 45%, you know, in the other studies. So even some real updated literature and across the 10-year study and tracking of that was quite impressive. I know we have a poll question coming up, but I'll usually give about 30 seconds in the chat box. Feel free to enter what has been your guess is the longest running group in Finland that they have going on right now. You got a little bit of a comparison with this study here, but maybe take a guess or throw out a number in the chat box, number of years the longest group has been running for. It'll give you some inspiration as far as how long groups can last for from there. So we have them flying in. All right, we have some ambitious numbers, which is good. All right, some good ones there. So actually one person nailed it right there. Their longest group right now is 12. It's actually 12 years and it's going on 13 pretty soon here. So it was actually the continuation from one of the groups in this study. So they'll be, I think, hitting the 13 mark shortly here. So if you're able to get a 13-year group growing, please tell us how you'll do it. We'll be following your lead. So that's will be you know, certainly something as far as long term that's a huge benefit. But even staying connected that long helps too. So again, just the rehabilitation model enhances security, increases better communication, and really the principles of group dynamics and the maturation of the group is really one of the goals of this. As a facilitator, you want to stay really patient with the Circle of Friends group. Again, you don't want to go in and thinking it's more so anything therapy, anything you're directing people to. It's sometimes tough because you have to let personalities work their way themselves out, because you're dealing with 5, 6, 7 different people with different gauges of loneliness and isolation. But I think it's really neat to see how the group really helps themselves. And you can almost be like a facilitator or kind of traffic controller, I like to say, within the group than necessarily a therapist or provider, more so. And as the group matures, bonds get strengthened over time. Conflicts with friends, with family, with others get resolved. We've even noticed a few caregivers have reported through emails and other things that people are really finding benefits from it. So we really like to hear that. One more kind of busy slide here, but this is kind of more of a filtering process slide. So when it starts with the group process and dynamics of finding group members and doing initial interviews, this talks on the right about the Circle of Friends trainings that happen. Really, once you have the recruitment and the interviews done, you know, really you want to address the group dynamics and kind of go through a timeline approach here, discussing loneliness, how the experiences of loneliness have been affecting each other, you know, how you provide a peer-to-peer support, and then really the maturation of the group and independence of the group starts to happen. So, you know, I'll talk about the 3 different session themes, but really the ways that organically the group can work itself through. They start taking responsibility for the group after the 12 sessions. And then there's unfacilitated group meetings is what we call long-term, where the facilitator can come back and join the group later on. Finland's mentioned the facilitators might meet them at a a park or a museum tour or something within their village, have a meal with them. So I think there's really creative ways that they can do that. And then the long-term outcomes, certainly better social activity, making new friends, increased bonds, and improvement of well-being and health certainly is a huge, huge outcome from this as well. Again, some of this you can find on the Finland website, and I'll share that after the next break. So strategies to consider for the group interventions, some things to start with. Everyone has, gets the bright-eyed bushy tail and thinking I'm ready to go, but you need to have some of the technical stuff set up first. Interviewing participants before the group starts is really, really key. And I think that's something that our grad assistants that Marla and myself have seen, they've really done a great job interviewing people ahead of time, not only setting up technology, which we'll discuss later, but also an assessment of what types of activities people are engaged in, and just as more of a joining to see what their levels of loneliness and expectations of the group are like. You want to provide ample amount of time for connecting with people. So, we're formulating in, our updated manual from SLU for Circle of Friends that we're working on is a needs assessment. So what does every site need? Because it's not going to be the same for every site or every clinic. So really, kind of brainstorming with whoever you're working on with this. Why are we doing this? What's the goals of our population? What do we want to get accomplished? How much bandwidth of people and resources is it going to take? Can we get people connected with technology? So really understanding all of these things is super important, and making sure you allow time to go through all these things, a facilitation of activities, monitoring and processing the groups, and really evaluating what things are working well, what things we may need to alter or change in the group. And then really the facilitator's goal is to transition out of the group. So again, it's different than most groups that is facilitator or provider led. This one, again, is very much the energy from the group in maintaining itself over time. All right. So we'll throw in a poll question. We gave you a few hints on this on previous slides. We'll give you about 20, 30 seconds to enter in the chat box. After participation in Circle of Friends, what % of persons reported not feeling lonely or isolated anymore? Hopefully you give a more optimistic answer. It's kind of a hint.
Max, we have a question maybe while people are answering that you can address. Oops, I just lost it. Is there a type of curriculum to follow for this, for Circle of Friends?
Great question. So Marla and I, and probably more so Marla at the end, we'll talk about the manual we have going. And now there isn't really much as far as from the Finnish group. Their website offers information, and outside of flying to Finland at some point for the 5-day intense training, they provided some information on the website and some of the other articles and things there. But certainly we'll touch base, because a lot of it is kind of a guide map for activities and themes, but they also want to keep the protocol more open-ended for the groups to really strategize what's going to work. So, it's not like every single session for the first 15 minutes you cover this. It's not a protocol like that. You want to engage and kind of loosely use the themes throughout, but really spend most of the time having people connect and feel less isolated.
Okay, one more. What are some examples of group fits? How do you fit people into groups?
Oh, okay. So like from the recruitment standpoint?
Right.
Okay.
I think.
Okay. I'll share the answer on the recruitment standpoint. I mean, if there's a different view of the question, feel free to add on to that. As far as the fit for the group, and we'll get to the criteria filter slide in a little bit too. really it's subjective feelings of loneliness and isolation that are feeling. By the way, just on the poll question, I'll answer that so we can minimize. 95% reported on the original randomized controlled trial feeling less lonely or isolated. So yeah, 70% was on some of the initial data, but as far as the main trial, 95% feeling less isolated. So, which is incredible based on what the group is able to offer. So the recruitment part, going back to that, it's subjective feelings of loneliness. There's no criteria or based on if we give a loneliness scale that it has to be within a certain range. We're using that as just kind of a pre-assessment. Same thing with the Lubin with social networks. So we use that pretty loosely. There's no criteria as far as mental health or other medical issues. Certainly we understand that that's going to come up. I think cognition comes into play big time. So if someone mentioned like the MMSE or we use the slums, if a doctor or a community member or someone makes a referral but says, I'm really hesitant because this person may have memory or cognitive issues, that may be a little bit of a challenge as far as someone participating thoroughly within a group. So I'd say keep that on your radar. Hearing and vision come into play a lot. If we're doing this virtually and someone is really, really hard of hearing, not that they can't do it, but they may have to call in by phone or really have a modification as far as hearing what's been going on in the group. Same thing with vision is concerned there too. And then technology, certainly if you're doing something virtually, you want to make sure that they have accessibility to get on or log on. Again, they can use the phone, but having some access to that it is certainly important. So it's kind of we try to keep the criteria open enough because there's a connection we want to make for people, and loneliness is kind of more of the gray area versus depression, where you can kind of monitor that based on other scores or things like that. So, all right.
And another question just popped up: is a phone-only group a viable alternative?
It could be, yeah. I mean, so one of our Circle of Friends groups right now, we have about 3/4 of our participants calling in. That half of that is because some of the members don't have access to a laptop or tablet, so they've been able to call in. I think that certainly can be doable, and as we say, any intervention is better than no intervention. But I think you're gonna have to tailor a lot of the group then. Just based on if you're going through kind of the circular questioning and checking in and going through things without visibly seeing like we are on Zoom right now with videos or where people are, you just have to structure it a lot differently to make sure you're getting through everyone because there's some talk over and carry over there. But that certainly can be done. For sure. You can share screen or show things visually too. So I think some of the recommendations and things like that also isn't as much what's on screen as kind of information sharing or things that they can do at home. So.
All right. Thank you.
Yeah, thanks. I want to be aware of time too with the break coming up. So feel free. I know as we get into kind of the technical stuff too, I want to make sure that it's more conversational mode than it is anything else here. So, yeah, someone mentioned the recruitment. So again, determining the need of your group. And I really will go back to the needs assessment and planning for that. Having a planning meeting is really, really important. Why you're doing it, what it will take, who's going to be on board, where you're going to have it, the who, what, where, when, how, why of a group, really important there. And then assuring too that there's support for the target group you're working with. Try the best you can, especially if you're doing it virtually. Work with a caregiver, have a family member's consent to be able to help them, whether logging on or just be in the loop. We found that that's the bridge really to get better retention in these groups than anything else. So, yeah, speaking of which, this was the filter slide I mentioned earlier. 65 or older, although we have had people in their early 60s. We have a few people in our groups who are 60. and it's actually in our, one of our groups that's been, already previously knew each other. Two of the women in their late 70s have actually helped the person in their early 60s, more so with loneliness. So, age is not a determination as far as, who's more lonely or isolated. Subjective feelings of loneliness, willing to participate. Again, telehealth access should have a phone or laptop. They pretty much have to, as far as connection goes. And we'll get to some of the telehealth stuff towards the end. Vision, hearing, mobility. So again, you just have to make sure from the senses perspective that people are able to pick up on stuff as well there. And then certainly on the cognitive and memory impairment part of that, you do that. I think getting feedback also from the caregiver family member on that is really good data, because sometimes referrals you get may not tell a lot based on memory or cognition, but that's something we ask family members too. Is your loved ones, their, memory, cognitive awareness still good enough to participate in the group? So if they meet these criteria, or at least as much as they can, then, you're good to go. Group member selection. As you say, loneliness is subjective, so you always have to ask someone if they're lonely. It's not like a universal standard. There's a lot of variation on how people define loneliness as well too. So knowing if it's a self-referral, if there's any measurements that you need to do. Again, we do the UCLA and Lubbock pre and post, but if any referral places do have indications or scores that people are lonely, that helps. Again, our primary care docs and geriatricians will send over. I asked a few questions in practice. Someone did feel lonely or even depressed. We feel this group would be really beneficial, or they have an existing PHQ-9 score, Beck score of so-and-so. That doesn't happen all the time, but it does help. Interviews are a must, as I mentioned before. And in the orange highlight sentence, elicit the person's goals and wishes for why they want to be in the group. Every person's going to have a different motivation for why they want to be in. I want to make new friends. There's not a lot of family in town. I've been widowed the last year. I've been just very isolated and really needing to just, connect. My provider said so. So there's going to be just a range of definitions on why people want to connect. And then a really key thing is identify the challenges or barriers in your group early on. Not that you can perfectly eliminate all of these, but the more that you can anticipate, the better. So again, if there are visual or hearing challenges for people, how you can adjust audio or maybe email over to the family member or caregiver some helpful tips really helps. Certainly if you're doing this in person, transportation becomes a real big key. We tried to build into one of our previous grants, although we had to go to obviously telehealth for our cognitive stimulation groups, but at the end we were going to do an extension C of using money for van service or transportation. Obviously post-COVID, that's going to look a lot different. Virtual does eliminate that. And I will say, when we did qualitative interviews with caregivers and loved ones who participated, they said the transportation and eliminating that was a huge, huge benefit for doing this on Zoom and virtually. So obviously you lose that in-person interaction, but a lot of them can't walk on the ice or up our ramp in mid-January to our clinic versus just, staying in their living room in comfortable clothing, being able to participate. So there is a comfort level that you're able to work on there. I'll go through just the planning sessions and then we'll be able to get to a quick break right there. Again, the potential structure of the group, determined by appropriateness and interventions. This is a closed group. So a lot of questions come up. If a person wants to enter into a group, when do you have the entry point? We say the cutoff is really after about the third group. So when you're starting really session 4, you should have your consistent number that you're continuing in your group. I think anything later than that, it really affects the dynamics of the group because they really get in a rhythm. The person that may enter in group 6, 7, or 8 session, they lose some of the early half of activities, getting to know stuff. You should always have 2 facilitators on deck. I always give the comparison This was in cognitive stimulation, but we had a facilitator that had to cancel that day. So I thought, oh, okay, I've done this enough. I'll take on the 6 people in the group. Why not? That day we had one person who simultaneously, 20 minutes in the group, had to go to the bathroom, one person who was crying because they couldn't do the activity, and another that wanted to walk down the hallway to stretch his back out. So I had 3 people in 3 different states trying to monitor that. And that was more of a, oh no moment. what was I doing? So we were able to figure it out. I actually got a front desk person to help take one person to the bathroom and help the rest of the group. But always have 2 facilitators on deck. Even if you're doing this virtually, it can help kind of give another perspective as far as evaluating what's going on. You can either also use one-to-one groups in breakout rooms if someone's really struggling, or that one person can call or talk to the person after the group. So always have at least 2. Make sure that members provide feedback after each session. We'll get into the arts exercise and writing in a little bit. So make sure that the meeting includes at least one of those themes or multiple themes in there that's integrated. And what's really helped us is having diaries. So we thought of that only in our childhood, but it can also be used professionally. So being able to track your personal notes of what helps in groups and being able to see what works with the intervention, what you're picking up on nonverbals. If someone's really depressed or really struggling that day, write that down. Sometimes one facilitator picks that up, one doesn't. So make sure that you're really able to see what's going on there as well too. So input from the members, but also facilitator communication is really, really important. Because again, you're not just doing a one-person therapy intervention on a group. It's co-facilitated and participant-led, and the facilitators kind of input the feedback from the members. So it's kind of very much circular from session to session. So the session agenda and content, again, as I mentioned, having a loose agenda is very, very important. You don't want to structure it down to every 5 or 10 minutes, because it's not going to work that way. But also you're allowing for the participants to really engage well. So these are some of the short list of areas that are really going to help that people talk about: resources, peer support, across the life course, what their goals are, future plans, where they're at in their family right now. We'll get to the Q&A slide a little bit later, but if people are really struggling, you want to help them out, but you got to make sure, keep the boundary, doesn't turn into group therapy or psychotherapy, because 1 or 2 could really be struggling and the group says, oh, well, let me ask some questions to see how you're doing. And all of a sudden 7 people are playing therapists. So you don't want that to happen. You still want to promote things. And on the bottom part, set some ground rules. I'll cover that later on. That's really, really important. The session components, there are 3 main areas: the art activities, the group exercise, and the therapeutic writing. Again, you can integrate several of these at once. These are a few of our pictures, by the way, from Aging for Developmental Disability and CHIPS in the public housing that they're doing with groups. So they're able to engage on some stuff. So, and they have smiles on their faces, which means they like doing it. So that's always good. So the art inspiring activities in the discussion. So it doesn't necessarily have to be in order. We normally do the wellness first part, then arts and hobbies and activities, and then therapeutic writing. But you can mix and match based on people's interests. Now, all of these, certainly, or most of them, were done in person before. The cultural events or visits or discussions in person. Since we're doing this virtually, we have to be creative. One of Marla's graduate assistants had an amazing idea doing a virtual tour of the Louvre. And so they got to see all the different art, the Mona Lisa, all different things going on. It was really, really neat. And, really conjured up a lot of things that people, either wanted to see, or maybe they went to Paris at some point in their life. So doing a lot of these things virtually is really going to help. Not only from the activity standpoint, but people can really share what they've been doing week to week. and really be creative from that standpoint. The group exercise and health discussions, again, we're not able to do mindfulness meditation, yoga, or like group stretching exercises. We have had a few guest speakers come in. In one of our groups, we had a PT that came in and talked about chronic pain, arthritis, sciatic pain, how to overcome that, and some tips. Feel free to bring in group members and guest speakers. I think Zoom, that's your captive audience. If a lot of providers are working out of home on Zoom, that's where you can capture that you normally can't. We share a screen once in a while if there's chair exercises, or you don't have to make them try it. I wouldn't encourage that the group members start walking and trying it in a different room. Always make sure they're on the screen. But as far as kind of engagement, have you been doing any walks this week? What have people been doing just to get out of the house? Simple stuff like that really, really helps. And then the third major theme, therapeutic writing. Now, this is a little bit more challenging because you don't have people in person or have a journal or a diary to write. The question earlier that Marla and I addressed, especially if male participants don't want to do writing or would rather verbalize things than actually track things from session to session. You can get inspirational quotes that people can bring, what's been meaningful. If people want to share different cards that they've sent to family or received, they can show that in the screen, so they're able to interact with that one-to-one. So this isn't really as much homework. Certainly if people want to interact, they can do that. One participant brought up a blog idea, which I thought was pretty cool. I haven't even started a blog, so I told them, I said, you're gonna have to teach me how to do it. So it's some really neat things that they can really launch from there. And then as far as preparing to begin the group, again, the logistics, this is just a summary from the other slides. Conducting the assessments, obtaining consent forms. I think that can be important, especially if you're working in a clinical setting or an agency where they may be your clients. I think that may be important to obtain. Again, that depends on the groups. And then preparing for the sessions again. So really having a loose outline of what you want to cover. But if you want to do virtual tours, guest speakers, I would plan that ahead of time to make sure that happens. And consider rituals. We do that in our cognitive stimulation groups, bring up a theme song. You may have the Beatles, or I know one person was really into John Denver, and the groups had some ideas on which musicians or what people they like. But even if it's not a group song, maybe just talking about music at the beginning really helps. So that's always good. Again, we covered the principles earlier: security, communication, dynamics, and maturation. If you hit on those principles in the group, you're going to have a really successful group. And again, a lot of this comes organically from the group. It's not anything we necessarily force. A lot of that really occurs naturally. Final slide before we get to break. And this is some overall recommendations. Again, the interviewing participants is something you want to do, and discuss the goals, not only that the group has during, but at the beginning. I feel like with any group you start, having the first session of a get to know each other. Every single group I'm in, I only laughing as it happens, I think of this analogy. It's almost like the high school dance where, you have everyone kind of in corners and no one wants to really talk or engage yet because they're kind of nervous. And then in the fifth or sixth session, everyone's dancing and the music's going. So it takes time for the groups to really evolve, but really get to know at the beginning what their individual and group goals are. Discussing loneliness and making it interactive and fun. That's really the key. So I know all of you have wonderful interprofessional and interpersonal skills that you can engage with older adults. That's what really this is about. It's not number of years of experience, number of letters after your name. It's really, if you have experience working with older adults, you have great communication skills, and you can adapt some of these techniques on the fly, you're going to have a really good group, and the facilitation is going to be really, really effective over time. So All right, I think we're at break.
We have a few questions, Max.
Sure.
Why is it important to know the individual's goals and wishes for the group?
So I think it's important because two things. One, we just want to know people's motivations for wanting to enter the group. Obviously, reducing loneliness is going to be something I think that's obvious. I think also there's different motivation levels that people have. One person may say, my partner wanted me to get in this. I don't really know how much I'm keen on it. So we know their motivation level and kind of work slowly into the group. And someone says, I was all over this once I saw your flyer. I need this. I'll be there at every group. I'll engage wherever possible. So I think from a motivation level, you have to gauge where your participants are at. I also think that getting the activities and knowing their interests sometimes can be a good commonality that you can bring into the group later on. For instance, a gentleman, he was, again, really into old music from the 40s and 50s. And we captured that in activities log early on. And about the sixth session, we said, hey, from your activities log, we had the record player playing old music and all that. Like, is that still an interest? And all of a sudden, he just sprung to life. He was an introvert most of the sessions. And once we brought that out there, we couldn't stop having him talk. So I think engagement and motivation levels, two big reasons why we do that.
All right. The next question, just to clarify, we make sure that we have 2 facilitators at each meeting, or have 2 facilitators trained and ready in case one cannot attend?
Ideally, you want to have 2 at each meeting. And I would make sure obviously 2 are trained ahead of time to be part of the meeting. I mean, if you have the bandwidth to have a backup, that'd be great. If you have smaller groups virtually, I don't think it's mandatory, but it's highly encouraged. I just think, again, for 2 reasons. It's backup if one person can't make it, but also the second person can pick up nonverbals and things while the lead person is just trying to organize the group. So when you're doing more of the comparison and in between session check-in, they can really pick up on stuff the second person that the lead facilitator may not be able to pick up on.
Okay, and the next question, for organizations that primarily recruit participants by throwing out a promotional net and enrolling on a first come, first service basis, how do you suggest they implement the screening actabilities?
As far as being able to screen people as they come into the group, I think is from a, so I think the screening and assessment, we always set up a separate assessment session. So we kind of do a preparation session with every group member we're in. So usually if it's like a 30-minute Zoom call, or if they can log on by video, to make sure that their screener technology is working, and then we'll do the assessment and run through the purpose of the group. If we can have a family member on, or at least call in, that helps, so that they can be engaged, and we can tell them, if there's any troubleshooting we need to do later on, we want to tie you in there. So you just got to make sure before you start your group, really like a week or 2. Normally we keep like a week or 10 days open for assessments, and that's our assessment week or 10 days before the group starts. That's what we try to do. But yeah, the pre-assessment separate session is crucial, because you don't want to be getting a few sessions in and already being behind on pre-assessments.
Okay. Next question, has this program been approved for other languages? Spanish?
I have not seen anything in the research in Spanish yet. I know that I've actually seen in articles and areas that they're looking for ways to promote this in Spanish-speaking countries and areas of the world. I haven't seen any evidence-based results on that. I could be wrong. And, Marla may know something on that too, but I haven't seen anything.
Nor have I. I think most of in fact, all of the actual evaluative data that I've seen in studies have just come from Finland. So,
right.
But you want to do a Spanish speaking group? That would be a first. That'd be great.
That would be really cool. Yeah.
Okay. What do you do if they're not accepted in the group, and how harmful is that? So if you have I'm assuming if you have someone that you don't accept into.
Yeah, well, I mean, we have several referrals on deck for sure for us. I mean, I think based on their needs, I think that's one thing we assess for. I mean, if there's more counseling that's needed, we have referrals. If there's more areas around like cognition or, either home health or there's homebound issues, certainly we would refer to some of our other medical providers. But I think that's a really good point. I think to have a list of referral sources as you start the group in case people can't join, or even if they do and they need those. We found people may need the referrals as much as when they can't get into the group. But and we use our geriatric assessment clinic a little bit too. We've had a few referrals that Marla and John run, and it's it's been a crossover between Circle of Friends and the assessment clinic. So.
All right, and I think Marla answered question that was asked in chat, and that you do have sample flyer and is in the manual, which you're going to be happy to share. So I always want to know about flyers and press releases. And I think with that, we can go to break. Great questions.
Really good.
In the interest of time, I'm wondering if we should go with a 5-minute break because we still have some ground to cover and don't want to miss out on anything. What do you think, Max? That work for you?
I think that sounds good. Five with a bonus minute. 5.
Okay.
Yeah. But yeah, thank you all for hanging in there. Great questions. Real quickly here, just as a plug, if everyone can see that, this is our Aging and Memory Clinic website. I'll put it in the chat box at the end. You can just Google SLU Aging and Memory Clinic. This has information that we have on Circle of Friends, cognitive stimulation therapy. We have some selected publications that we have. You can see that we've done presentations, speaker series, and then we have some videos up there as well too. So we're putting a lot more information and disseminating stuff up there. So we'll make sure that if you have another resource and something you want to look at, that's there. So okay, so I am going to get to group process and training. If everyone can see that, I think we're all set to go. Try to be prompt here as well to get through this because I know we'll have some wrap up and any Q&A at the end here. So we'll get into group process of Circle of Friends groups. So how do you co-facilitate groups? There's a good question before around having at least 2 facilitators. And again, it's not about the letters after your name or degrees or years of experience. I think if you meet, criteria of being process-oriented, driven, highly interactive with older adults, and being self-reflective, a lot of participants want to ask you questions. So making sure that you have a really reflexive process throughout the group is really important, and being committed to the program. If they want to continue afterwards, be open and make sure that you can fit in time down the road, a month or 2 or 4, if they want you to meet somewhere or want you to log on. If you want to be in this for the long haul and really monitor it and kind of show the value and utility of what you've done, that's really important. Members certainly can vary and do. We have two pretty diverse groups in St. Louis, and a third one that's going to be starting in January, where we draw a lot from our communities. So again, I think this is going to change a lot based on what population or what setting you're working in. Community driven is going to look a lot different than in a specific center, in a clinic, in an organization, just based on your population. So the facilitator self-assessment, something that you should really know about and kind of do a needs assessment, not only of the group, but of the facilitators, motivation to facilitate, the experience and knowledge, again, around this. Certainly if you have graduate students, early new professionals, they certainly can qualify because, we have a lot of graduate student and early social work, marriage and family therapy professionals who are running this and doing an outstanding job. The commitment to the population for older adults and really empowering individuals in this group to make friends and stay connected through this is a huge motivator and a huge factor. So the facilitation skills at the beginning, I'll kind of walk you through the beginning, middle, and end. Again, the first session or two is going to be introductions and really discussing the purpose and goals of the group. And we always encourage people starting a circle of friends group to establish ground rules. It's not set in stone, and it's nothing where people are going to get banished from the group if they don't abide to it. It's reminders. Make sure you're respectful to others in the group. Be sensitive and be respectful of people of different opinions than you. If you have anything that wasn't addressed, feel free to contact us after the group. Stay within time limits if we ask as far as a check-in. We'll get to the personalities of group members a little bit later. But again, assessments and skills, knowing what the goals are from the group, the first couple of sessions. Again, if you have a few people filtering into the group in session 2 or session 3, keep revisiting what are the goals, what do all of you want out of that, or are there continuing things that we can offer, and addressing as well if there's any strengths and things that people are doing well. We often found at the beginning of groups, if you can really validate people, it makes a huge, huge difference. The more that they can feel welcomed and normalize their feelings of loneliness, they're going to be much in it for the long haul. In the middle stage, in kind of the 4 to 5 to 8 to 9 range for sessions, not only the goals that they're working on, but being able to monitor the activities and things that are happening in the group. As you get towards the 8, 9, and 10, I think that's where the group gels really well. And you can kind of back off a little bit. Again, if you need to put in the ground rules or a little bit of structure on time, you can. But one of our facilitators, he said, I just let the women in the group go and they go. And he said, my biggest challenge is interrupting and having to intervene them because they have so much to say and they want to catch up on everything they've going on, which is great. So this is, again, just a platform for them to do that. And then the ending and continuing stages, again, the preparation point. Now, probably around session 9 or 10 is when you want to introduce the idea of not only, session 12 protocol where it's facilitator led, but does the group think about wanting to continue afterwards, or what are your goals for what you want beyond this? Now, not everyone may be on board. Not everyone may be comfortable as well in the group saying, I don't want to continue, and that's okay. I think you have to make your determination on how many people is an appropriate amount going beyond just the 12 sessions. I think even if you have 3 to 4, that's still enough that you could continue a pretty solid group. But certainly if all of them want to, then you've really done well there. Again, make sure that you assess and, revisit how things went. Maintaining the maintenance and sustainability plan is really important. So being able to prep the 1 or 2 champions of the group saying, what ideas do you have? Make some early preparations. One of the facilitators should probably talk one-to-one with them outside the group of saying, thanks so much for doing this. What are your ideas as far as sustaining it over time, which is really neat. So that's usually kind of the leader when getting into now the member roles that we have. But these are some of the more challenging ones that we see. It's not all inclusive, but I think this will be in most groups. You often get the monopolizer, the person who wants to talk about their entire week. They want a story about the barbecue and how the grill didn't work for 25 minutes. Where if you have 6 people in a group, you may have to time limit or just say, we'll just kind of set about a 3-4 minute time limit for check-in. And then when we get to some of the bigger areas, it's kind of open group discussion. But a little bit of structure is important so that everyone can do that, because monopolizers are in the group. There's also the opposite, the introverted, the quiet members. They may be a little bit more hesitant to talk. Now, one thing you can't assume is that quiet or introverted means more loneliness or depressed. It may just mean a comfort level in people interacting in a group. Maybe someone has had a one-off day where it's been really bad for them. So don't assume at the beginning that people are struggling. I think that's where the facilitators need to really check in with one another to see what's going on. Then you have the higher functioning member. I don't think it's necessarily a bad thing. I think one of the challenges you get with people who are maybe not as lower on the loneliness, or maybe have a little more resources in their life, they may try to act as the facilitator themselves, or say, hey, you know, I want to set some of the ground rules or things like that. So, which is okay, but I think the facilitators just have to assert themselves a little bit in the group to make sure that the group members aren't kind of overtaking others in there. But the higher functioning can certainly be your champion as they go forward as well too. We didn't add in here, there's the troublemaker that sometimes happens. So they'll throw out a few sarcastic things. Obviously, this year with group interactions, you've got quite a number of things that could come up that would be, I don't want to say controversial, but a difference of opinion, vaccines for COVID, the election, social justice issues. There was certainly enough to work with in groups. So they're open opinion, but making sure that they're interacting is really important. So just some sample Q&A of questions that come up that we get about groups. It's difficult for people to come to sessions, but once they do, they really enjoy it. How can you encourage them more? I think, again, bringing in the family and caregiver is really, really vital to make sure that they give reminders. It may also not be that people don't want to get to the group. They may forget on their schedule, or there may be other tech challenges that happen as well too. So ways that you can try to bring them in that are creative really help. On the second one or two members, again, are the monopolizers. They take over stories. How do you manage this? Always goes back to the ground rules. So if you have a list early on, that really helps. And also, you may want to talk to a one-to-one with that person, or maybe their family member outside of there if it gets to be really problematic, and just say, hey, if you could just give them a reminder, or we just want to, we appreciate all the input and advice that they're giving, but we just have to make sure others in the group are handling that as well too. So kind of a soft approach maybe outside the group can work. People are displaying symptoms of clinical depression or more psychiatric issues, how to support them. Again, to address the question before, resources and having multiple referrals on deck, I think is really important too. You also want to monitor to make sure that people can feel depressed or lonely, but it doesn't turn into a psychotherapy group if one or two people are really, really struggling. That, again, you're monitoring that, but also giving them enough outside the group. This is a really important area too, with cultural values and norms. We always try to keep in mind group members are diverse. They come from different backgrounds. That's something we try to always encourage in our groups, especially talking about what they do in their communities, how their families are diverse, and maybe didn't attain a certain level of education, but what they did in their life and their accomplishments. Or we get others that maybe still working a little bit, and others who have been unemployed or got laid off or retired for a while. So again, the sensitivity where people are at in their background is really important. And also hit on the third point too, from religious faith, spiritual aspects, to embrace that people are coming from different backgrounds there. Sometimes they may not take on the suggestions from the group, which is okay. They may have different ways of being resilient or coping with loneliness based on their own personal or cultural values that they have. So I think that's always one of the more fascinating things that we can discuss and talk about in the group. So I think from a facilitator perspective, just be mindful of it, but I think also embrace the diversity if you're able to get that, because there's been some really, really neat conversations around some of that stuff. So kind of the takeaway points from it, don't assume that everyone's the same. Again, everyone's coming from a different background, a different situation, their family behaviors and meanings they have, and the amount of support or social connections may differ all across the board. So what you think may be normal, for, older adults, culturally may be different for some people too. So clarifications around that is important, and that people understand if there's a suggestion or a meaning or a takeaway, that it's understood by everyone that's happening in the group. We'll get to evaluation and process now. So again, the assessments, both pre and post, make sure you check in with group members, again, how things are going with the group. And if the facilitators can check in, ideally between as many sessions as they can, or at least email just to check in to see how it's going. Again, having that 2 at least per group, there's a comparison for how things are going, and there's ideas that you can get for future sessions from the members. And then just, remember, if you're doing pre-assessment, to always follow up with post-assessment after the 12 sessions. If the group is open to doing like a long-term, 3-6 year-long follow-up, if the group lasts that long, that's a good problem to have, making sure that you have access to someone to follow up to see if there's long-term outcomes from that. Again, we know a lot that happens in person. We don't know a lot virtually that's happening with Circle of Friends. So this is uncharted territory, and we're really building the ship as we sail here, I think, virtually with older adults. Termination and transitions, again, prep early as far as when you're going to be terminating. Plan a celebratory last meeting. So if you're, people can check in and you can make it fun, making sure that people can, share their experiences and their celebrations. I can't find the clap or thumbs up button on here, but you can see that on your Zoom. Many of you use it, that reaction button. People give, those fun kind of celebrations for people who have done it. It's a real accomplishment. I mean, when you think about it, someone's isolated enough that they can't find any connections, and they commit to almost 12 sessions across 3 months with either strangers or people they know but have felt vulnerable with. That's a huge accomplishment. So, give them some validation and encouragement that they want to continue, that they can, and how the facilitator, as pointed out here, can be incorporated back in there, and can give some tips as well too for the group. But if you have a termination session, some goodbyes, and that the group can still keep in touch, even if it's not a structured group, from the participants afterwards, I think is really important. And then finally, with the reflective learning and learning cycles, again, making sure that you do continuous feedback and continuous improvement of your group and going forward is really important. Again, I mentioned the writing and especially the journaling that takes place. I think that's really important, that you want to track down notes. Sometimes in the first group that we launched, that was a pilot group, I remembered very little from the group, and then I had scratch notes, and another student gave me some of their notes. I thought, oh, okay. I didn't even pick up on that one person's point or what they were getting at struggling. So again, continuous feedback and reflective learning is really the key. I think you learn just as much from qualitative feedback on their written and verbal responses as you do quantitative. Because obviously you want to find improvements of loneliness, but if people can verbalize that or find more meaning to it, makes all the difference in the world. I'll finally end on virtual delivery. This is in our world right now. So this is just some of the tips Very important stuff, though, to keep in mind whether you're doing Zoom or Teams or any other platform. I went through the first three as far as common issues. The fourth one that applies to telehealth, if you have those that want to attend, but they don't have access to, let's say, a computer or a tablet, could they use a phone? Absolutely. Again, they have to have some means as far as connection. We do have one participant who wasn't able to do either, but what we decided to do is have one of the group participants pass along information and kind of major themes to the group, like paying it forward to the person. And it was really cool. And the person getting the email say, I want to be connected in what I can get from session to session, which was really neat. So they couldn't make it for scheduling reasons and didn't have a laptop or tablet at their home. Again, just the more connections we can make out there, the better. This is pretty self-explanatory, but just, again, some useful tips to remember. Confirm with group members ahead of time that audio video is working. We've always kind of thought of ourselves as the Best Buy tech support the first session or two. And it's true, you're going to be doing half of it kind of IT and managing the microphone and, whether they're backed up too much or they're, looking in the screen and, making sure the, visuals working. So again, making sure that things are set up there. A share screen option you should always do, at least for people on video, and then explain to people on phone, this is what the group would be seeing right now, and we'll describe it for you. So don't assume with people calling in that they're knowing what you're reading off the screen. Tracking nonverbals is important, and then definitely anticipating distractions, because there's a lot of it that happens obviously on Zoom and telehealth in general, and Wi-Fi connection and all that. Making sure when you start up sessions, the date, time, and link are correct. Definitely make sure on that. Always make the option for participants to log in early. I know with waiting rooms and certain things for meetings and presentations that make sense. Once in a while, when participants log on and they see a waiting room or they don't know that, they may log off. And so they may say, oh, that may not be the right group, or they may get confused. Always try to have the easiest access point for participants getting in as you can. Don't create more barriers than they need to. It makes sense for presentations and webinars, but for groups or people are new to Zoom or meetings, early access is important. And don't conduct a webinar format. You always want to be able to hear what they're saying. Sometimes they can share a screen too. We've had a few people say, hey, I found something interesting as an article, share a screen. Then they can bring it up. And for those who know how to use it well enough, they've done it, and it's really cool. So, and then final thing I'll show, this is an editorial that myself, Marla, and John have put in the Journal of American Geriatric Society. And I can show you the article at the end if needed, but you can also Google it. This is on this column, in-person activities for the themes, and this is how you can adapt it virtually. So these were all suggestions that you can go from in-person to virtual. It's certainly not a standalone. It was kind of more of a template as far as where people can adapt them, but you can see the more in-person stuff, in nature walks, swimming, yoga. Now you have to do more guest speaking or, check-ins of what they're doing with chair exercises or things like that. So, making sure that they're monitoring that certainly is important from that perspective. So I know we're nearing the end, so I wanted to pass it over to Marla. I don't know if there's going to be any questions in Q&A.
We do have questions. Do you want to take them now or after Marla?
Oh, go ahead while I'm pulling up my final slides.
Okay. So one of the questions, what do you do if the number in the group starts to shrink due to illness and death?
Good question. We did in our pilot group have a woman who stayed for about 2/3 of the group and then just had pretty serious health issues. We give it kind of fully up to them as far as how long they want to maintain in the group for, while making it obviously safe enough. And if a person can't stay into the group, we encourage, and the group has always communicated or contacted them outside of the group. So as long as we still have a connection, even if a person can't or has a chronic or even terminal illness, we've connected with them. But that's been a priority of ours. We stay connected.
Okay. Do you have a list of rules for group interaction?
So yeah, we a little bit in the manual. I mean, loosely as far as what we've been developing in there. But I mean, if people want that, and I could certainly send that along to Danielle. We have in a few of our groups kind of different ground rules, but templates that could help.
Okay. And Marla answered this, but just in case someone else missed it, someone had asked if there were, if pre and post evaluations for each participant are required. And Marla stated that they're not required, but they are helpful. And there's a whole bunch of other things that came in there, sorry. And can people exchange information so they can continue on their own if they want, and facilitator can be available if they want to?
Absolutely.
Yes.
And that's actually it's strongly encouraged, not only for the group dynamics, but to sustain it. I think that really has to happen. So yeah.
Okay. And after this presentation, are we ready to go back to our organizations and start Circle of Friends?
I hope so. We strongly encourage it and back that. We trust all of you to do it. So.
And in fact, I think, and our final slide that you'll see in a minute is really that Danielle and the Casey Shepherd Center have agreed to sort of be a hub. Max and I are more than happy to kind of do an informal Zoom with people. If you've got questions, we can, if there's a group of people who connect with the Shepherd Center, we can Zoom in and answer questions and help you get started. We're doing something here in the St. Louis area in 2 weeks, I think, where we're bringing all the people together who are facilitating groups to just share strategies. Since there really is no curriculum as such for this, where everybody's kind of developing based on the group members' interests and needs. They've been doing a lot of different activities, so we're bringing a think tank, resource sharing, whatever, I don't know what to call it, together. So we'll let Danielle, unless there's any more.
Yeah, there's, do participants pay anything to be in the group? And when will the manual be available? Are the last two questions.
I can address the first one. Marla will be better with the second one. Yeah, our groups are free. Now, we do that because we're covered under research. And so when we've been doing research studies, they've been free from our sense. Billing and stuff is a whole nother topic in itself as far as from agencies. But yeah, if you do it under research and it's covered under there, for us, it's been free. And same with some of our community partners too, so.
The manual is, in fact, there's a slide with my email on it where you can email me and I'll be glad to send the slide. Or send slides, send the guidebook that we've developed. Please understand though, it's a work in progress. The Finnish group has been immensely generous in sharing this intervention. Unfortunately, so many of their materials are not translated into English, as is their website, which is good. But so we've had to kind of create things from scratch. So we consider the guidebook, the manual, a work in progress. So let me just real quickly here say kind of next steps would be to start off, with your action plan. We do have a copy in the manual of the action plan. Just really, it's a needs assessment, if you will. What do you need to get started to sustain the group? Do you have all the things that you would need? Do you have a pool of people? How would you recruit? That kind of thing. It's all, Max talked about that. Kind of our final takeaway here is just back to the It Takes a Village theme. We need at the individual level to to, you know, have a group of older adults who feel safe to be able to come together and have their needs met. We need to increase education and awareness for family, community, and certainly for society. So again, that's why I was so glad to see that there are people here who work at all levels, because I think it takes us all to address this issue. We did have a question earlier about the recruitment flyer. Here is actually what our current recruitment flyer looks like. There's information about the SLU Memory and Aging Clinic. And we do have a copy of the template in the manual as well. So that can serve hopefully as a guide. Here is the current version of the training guide. And to receive a copy, just please shoot me an email at marla.bergwager@slu.edu. And that will be in there as well. We've also, just a second if anyone's writing that down, marla.bergwager@slu.edu. And we included here, I won't go over these, but just when you see the recording there, we've included a number of resources that hopefully can be helpful. The Circle of Friends website, our Gateway Geriatric Education Center website. AARP has excellent resources for addressing loneliness and social isolation. Sage Connect has set up a volunteer check-in, a phone check-in with people. There's some national social networking sites specifically for older adults that are you know, good strategies for some people, not necessarily something everyone would want to pursue. If you're interested in more reading and some websites with additional information, this is, we've just listed a few. We referenced many studies and research projects. Here are the main ones from the group in Finland. If you want a full reference list, again, just send me an email. It's a daily, sometimes expanding list of references, because as I mentioned earlier, there's just an explosion of research in this area right now. Some geriatric education opportunities through our GEC. We've got an asynchronous webinar that'll stay up through the end of this year on the impact of COVID on older adults. We weren't able to have our 31st annual Summer Geriatric Institute in person, so we pivoted that to a two-part online version, and it is also available. There are CEUs available for both of those. And then we are hopeful that we will be back in person for our Summer Institute on June 2nd through the 4th in 21. We're hoping we'll be there in person. Here is our information, my email and phone number, as well as Max's. And I wanted to just end here. And we came in a little over a minute past 12 o'clock. So if you're able to stay on for any discussion, Danielle, I don't know if you'd like to chime in about what how people might want to go about reaching you, or trying to form a hub for Circle of Friends in the Kansas City area.
Yeah, let me put my video on. Yeah, Kansas City Shepherd Center is very excited to be a hub here in the Kansas City area. We think that the Circle of Friends program is just a great benefit and really needed in our community. So we want it to be strong and have lots of support for anybody wanting to start and bring that on in their organization. So if you are interested, there will be a question in the follow-up survey if you're interested in getting information, being a part of that. And I don't know exactly what that's going to look like now. Will it be regular meetings on Zoom where we can just talk about, this is my challenges I'm having with my group, or getting a group started, or if it's a Facebook group or whatever, but we'll kind of let the group determine that. I also put my email in the chat here, so feel free to jot that down and email me if you are interested in being a part of that as well. So hopefully
Thank you.
Help each other through that.
Thank you, Danielle, for taking that role on. I think that, because what we've found here in the St. Louis area is those of us who are doing it, right now we have a grant. Three partners together have a grant, so we meet monthly to just, you know, kind of check in with each other, share resources, that kind of thing. But I think I'm hopeful we'll be able to continue that. And that really is part of the model, is for facilitators to have regular ongoing contact to support one another, share ideas, that kind of thing. So for those that are kind of willing to stay on, there's some additional questions, it looks like.
Yeah, one was on a licensing fee, and there is one, and I believe there's not.
There is not. This is, you know, I know there are for a number of evidence-based programs. There is not for this one.
Great. And then how do you find a co-facilitator? Do you have any suggestions on that?
If you're in an organization, it could certainly be obviously a coworker is the most obvious, but you know, I think don't dismiss the possibility that it could be a volunteer. This could be a great opportunity for a student if you are tied into the universities and have students. We actually have in the St. Louis area, there was someone who participated who is now going to be a facilitator. So I think that there's lots of different ways. This is not considered to be a clinical intervention. So, you know, it does not have to be someone with clinical training to facilitate or co-facilitate. So I think that opens up the possibility for lots of options.
Okay. If an organization wishes to charge a fee, is that okay?
I think so.
I think, yeah, I think they could. It would be different, obviously. Something goes through insurance or what gets coded for the group. That's different than if it's like a flat fee that people pay for the group. But I don't think there's any restrictions.
And I don't, you know, as far as we're aware, and we've not tried that, we've not tested this, because it's not a clinical intervention, you know, with diagnoses, we don't think it's a reimbursable service. If everyone were diagnosed, for instance, with depression and it were considered to be a therapy group, then yes, that's a reimbursable service. But as the model was developed and as we are promoting it, it's not considered a clinical service, as I said.
Right.
All right. And I just want to, so I believe we talked about this before. This is evidence-based, but you are going through a process to get it accredited.
Yes. Yes. Thank you for mentioning that. Yes, we've been in touch with the American Community Living contacts about getting this, as well as one of our other services, cognitive stimulation therapy, added to the evidence-based approved list. And my understanding is they accept applications for that periodically. And so I'm going to keep watching, and we'll probably get our materials submitted early in 21.
So I know that's maybe important for some of the MARC senior centers who get some reimbursement from MARC for evidence-based programming. So.
And I would also consider, I don't know if we have anyone here who works in residential care, but I think Circle of Friends would be a great intervention in a skilled care and assisted living facility, even in an independent community living situation, because I think that you know, people can be lonely in those situations as well.
That's been on the radar of a lot of funders right now, is in those types of settings. I think that's gonna be the next big area for sure.
I agree.
All right. Well, that's all the questions I have.
Okay, yeah, I'm not seeing any.
This has been really great.
Oh, well, thank you. Thank you for your willingness to carry it forward. And thanks to Mark, to Kathy, and to Carmelia for arranging this. It's been a wonderful opportunity for us. Oh, there is one more question here. Do you think meditation is something we can add? Absolutely. Absolutely. In fact, one of our grad student groups had a yoga instructor come, and she taught some meditation, breathing kind of activities. And now they've made that a regular part of the start of every group session.
Yeah. Our caregiver groups too do a 3-minute meditation in peace to start out. So there's complete silence. So it's a great way to start it.
Oh, and Anne is a certified meditation instructor. So everybody who starts
Nice.
contact Anne.
There you go. Bring you
Teach you how to do that.
Yeah.
All right. Well, if there's nothing else, thank you so much, everyone, for hanging in with us and even staying a few minutes later. So, and don't hesitate to reach out. We're happy to help you get started.
Yep.
Thank you.
Questions. Thanks so
Bye.
much. Take care.